Right now, it is estimated that the hospital industry alone is losing about $1 trillion a year to wasteful costs and unnecessary losses. The average hospital is spending about 30 cents of every dollar it earns on those kinds of wasteful costs and losses. As the healthcare dollar keeps shrinking, if we don't get control of that, this is going to be pretty ugly. And the only people who can get control of that is us, is our hospitals, because we understand patient care better than anybody from the outside can understand it. And we have to get control of this stuff.
Hello and welcome to this podcast on saving healthcare. My name is Nicole Travis and I'm here with Darlene Bainbridge. She has almost 50 years of experience in the area of healthcare quality, risk management, patient care, and saving at-risk hospitals. Today's podcast is going to focus on where healthcare is today and how it got here. So, Darlene, I'd like to start out by just asking you, what would you like your audience to get from this podcast?
I want people to understand, especially people who are making healthcare decisions, how healthcare got into the mess it's in today. Why an industry that once enjoyed tremendous power, influence, earning potential, and goodwill is now in a situation where its operating margins are dangerously small. It has a workforce crisis that just keeps getting uglier day by day. It's losing way too much money as it spends to the 100 in the 110-100 rule. And players who once only operated on the periphery of the patient-provider relationship are now driving the buses for how patient care gets delivered and paid for. And I just want us to understand why this is all happening to healthcare, because it doesn't make any sense. I have people say to me all the time, how can healthcare be in the mess it's in? All the money it's making, all the buildings it's putting up, and all those kinds of things. How is it in this situation where we are now having conversations about the potential of maybe around 700 hospitals dying, closing, leaving healthcare deserts for people in rural America? And so it's extremely important, especially right now with the economic state of the country, for healthcare to understand what it has to do differently in order to start turning all those things around.
So based on that, with knowing that that's what you want the goal of this podcast to be, what is your intended audience?
So my intended audience is anybody who has an interest in saving healthcare. But the people I really want to reach is the CEOs, CFOs, and board members of our hospitals, because everything we're going to talk about, every type of healthcare provider can benefit from it. But those are the people who can drive the bus for fixing what's going on in healthcare right now. They have to be able to differentiate between those types of decisions that are born out of 50-year-old hubris-driven assumptions that our predecessors made, and that every day hurt our organizations, and the kinds of decisions that will lead us to a better place. Free up money, free up manpower, give the American people what they're looking for. We're living right now in an environment where back in the 1960s, the confidence in the healthcare industry, public confidence, was around 85%. Today, it's estimated to be at 30%. So the question is, how can we be in a situation where we can do so many great things to save patients' lives and advance patient care and have public confidence be that tiny? And it's because of how we manage quality in healthcare and how we have managed it for the past 50 years. And instead of managing it like it's the two sides of the same coin, money and quality, like other industries do, we have focused on chasing the money that our new technologies create for us. And we have dismissed the importance of being in control of what creates cost, losses and frustrations on the other side of that coin.
Definitely. So how do you think that we got to where we are right now with the interpretation of quality? And probably one of the bigger questions is what does quality symbolize in healthcare? And then probably how did it get to where it is now with the philosophy and the idea set of quality?
So that's a really good question. And that's one of the reasons why I decided to do this podcast, because I've been doing this since I became a quality director in healthcare in 1980, back when it first became a requirement to have that position to get through accreditation surveys. So I've kind of seen the evolution of this mess right from the very beginning. And a lot of what was going on back in the late 70s and the early 80s was our technological revolution was taking off. And we were already struggling with some of the dynamics that were coming out of our scientific revolution that had started to play out back in the 1940s. And so when the technological revolution came along, all of a sudden we could render all this care that we'd never been able to render before. I mean, physicians used to run around with these little black bags, and everything that they could do for a patient was in that little black bag. And now all of a sudden we're doing more aggressive types of surgery. We're saving lives that we could never save in the past. And we got caught up in a belief that all that care we were rendering was somehow going to be enough to protect us, that we didn't have to be in control of the other side of the coin, where all the risks and the problems lived. And so what happened in healthcare was we started doing what Jim Collins describes as the act of chasing more. And that's where we were chasing more of the revenue-making things in healthcare. And we were not paying attention to the risk side of the coin, where if we hurt a patient, it almost was like it didn't matter, because we got paid to treat whatever came out of complications came out of the way we rendered care. And so we got caught up in this belief that we were going to make our fortunes and we were going to do everything that we needed to do to be successful by simply chasing new technologies. Every hospital had to have an MRI machine. Every hospital had to have everything, because that's where the money was. We were getting paid whatever we said it cost to deliver care. We were getting paid to treat every complication that came out of the way we treated that care. And we just thought we were in control of the environment, but we weren't. Because what happened is, as public frustration grew, outsiders who typically had been not allowed to necessarily have a lot of impact in the way care was delivered started gaining control through rules, regulations, survey standards, and all kinds of things. And instead of us recognizing what was going on and getting control of the things that were starting to hurt us because they were frustrating the American people, we just doubled down as an industry. I remember when I was a quality director in the 80s, my number one job was to make sure that the boardroom table was covered with so much paper when the surveyors arrived that we had a really good chance of having a great survey. My job was to impress them with how many new forms we created, how much longer the old forms were, how many new policies and procedures there were, how many steps we had added to procedures, how many educational activities we had conducted, and a lot of those types of things, how many committees we had created. And the one thing that was missing in that whole equation was the difference it all made. My job was to give cover to the way the hospital chased more, so that CEOs and CFOs and people in the C-suite could stay focused on that. Well, I'm over here making sure that we didn't too greatly challenge what was impacting the way we made money, and making sure that we always had great surveys and the regulators were happy.
What I hear you talk about all the time is that tit-for-tat mentality to appease that survey process without actually changing anything.
So tit-for-tat is a game-like strategy that dates all the way back to the 15th century. And that it comes out of an old English language saying, meaning equivalent retaliation. So our idea for protecting our ability to keep chasing more and spend our money on chasing more was to develop a quality model that was really nothing more than a game of tit for tat. Surveyors and regulators would come up with something for us to satisfy. We would figure out how to minimally satisfy it so that we could have a great survey. And then a lot of times not even worry if we maintained it after they left. And then because things didn't get better, we didn't gain better control of what was frustrating and hurting the American people, they would come in with another set of requirements for us to satisfy. And today, that's a huge piece of what our problem is, because we're still playing that game. I still have organizations saying to me, what do we have to do just to minimally satisfy the surveyors when they come in? And I don't want them minimally satisfying the surveyors. I want them getting control of this stuff so that it stops hurting them. It stops hurting their patients. And the surveyors don't have to write any more rules and regulations. We don't need any more survey standards because we're in control of our environment. We're in control of what hurts us. We're in control of what hurts our patients. And we're doing it in business smart ways. It's kind of like when I became the CEO of the hospital I was at. I was put in there to come up with an answer for a financially failing hospital that was on the verge of closing. And it wasn't too long after I got there that the surveyors came. And one of the very first things that happened in that game of tit for tat was the surveyor handed my med-surg manager a form that he wanted her to implement because he'd found it in another hospital. He liked it, and that was his way of being helpful. And when I asked him how the form would help us save that hospital, he just looked at me and he says, well, I don't even understand why you're asking me that question. It can't take more than 20 minutes to fill out. But it had to be filled out on every patient, every shift, in perpetuity. And so what happened is I said to him, but I can't afford all the staff it would take to support that form if it's not going to make a difference. And he and I sat down and we did the math together. And we figured out that it was going to take 5 nursing FTEs to support that form for every 25 patients we would take care of. And I said to him, and I can't afford to just hire 5 nurses to take care of this form. I need to know it is going to make a difference for the patients. It is going to make a difference for helping us save this hospital.
Yeah.
And so we didn't end up implementing the form. But that's what tit for tat looks like in healthcare right now. And we have to break free of the game because it's killing us. It's one of the primary reasons healthcare is losing out on all the money, manpower, goodwill, and stuff that we now need right now for our hospitals to survive.
And I think another good example of that is what we're seeing with some of the benchmark stuff that we're doing. Benchmarks can be used and they can be really beneficial, but when you're using it just to create that status quo to say, well, I'm at least running with the herd, you're not actually trying to improve yourself. You're just trying to show that you're where your competitors are, so you can run with that. Would you agree?
I would totally agree with that. That's one of the things that worries me the most right now, because as we play the game of tit for tat in healthcare, these little quality projects are a big thing, and so people will say to me, we're not making a difference. We're not getting anywhere with this. And it's because it really wasn't designed to get us anywhere. It's designed to play the game of tit for tat. It's like a conversation I had with one hospital CEO. And he said to me, he says, so we took an award and we're in the 95th percentile compared to the rest of the hospitals. And he says, so what do you think that means? And I said, well, what do you think it means? And he just looked at me and he says, well, he says, it probably means that on whatever the tiny list of measures we're doing really good. But it's probably not a list big enough to know that the hospital is making all our patients happy. We're keeping them safe and we're doing what we need to be able to do. And that's exactly correct. But what's happening is we're just consuming all these resources. Right now, it is estimated that the hospital industry alone is losing about $1 trillion a year to wasteful costs and unnecessary losses. The average hospital is spending about 30 cents of every dollar it earns on those kinds of wasteful costs and losses. And as the healthcare dollar keeps shrinking, if we don't get control of that, this is going to be pretty ugly. And the only people who can get control of that is us, is our hospitals, because we understand patient care better than anybody from the outside can understand it. And we have to get control of this stuff.
And this is where managing to the 100 and the 110, 100 rule falls into play, correct?
It is. So the 110-100 rule, I think, is an extremely important rule for healthcare leaders to understand these days. It's a rule that was first introduced back in the early 1990s by George Lebovich and Su-Young Chang. And they were trying to figure out how quality data impacted the business health of a business. All right. If you had good data, what impact did it have? If you had bad data, what impact did it have? And then the architectural industry grabbed a hold of the rule, and they kind of expanded it to impact business more in a bigger way. And so the idea is, if you spend to the $1 to get it right the first time, you are going to spend $10 or some version of that to make mid-course corrections, and you're going to spend $100 or more to fix it after the fact when it's already an error or it's already had some sort of negative consequence. And when you spend to the 100, you're really spending to some version of $100, $1,000, $10,000, $1 million, or more. And for in healthcare, those numbers just keep getting bigger. Yeah. Every day they get bigger and bigger. It costs us more to deal with medical errors. It costs us more to deal with surgical complications. And so our quality model, which is predicated on making spending to the 100 okay, simply because of the way the game of tit-for-tat is played, now has to be fixed. And we have to start managing everything and anything we can to the 100 to the 1, because we can't afford to manage to the 100 anymore. Here's a great example of that. I had a hospital I was working with. They had a successful cybersecurity attack. They figured by the time they got all done dealing with it, they lost or it cost them somewhere around $3.4 million. And so I'm sitting there having a conversation with the CFO I wanted to talk about how we were going to prevent it from happening again. That's the purpose of our quality programs, to be in control of the risks that can hurt us or hurt our patients. And so he finally just looked at me and he says, I can't have this conversation right now. He says, my priority right now is to get our new clinic open. And I looked at him and I said, but what good does it do you to open the new clinic if you're not going to be in control of how you're going to spend whatever money that clinic's going to make, which is a smaller and smaller amount of money all the time? And he just dismissed me and he says, I can't do it. He says, I just can't focus on this right now. He said, I got to focus on the clinic. So they got their clinic open. And then they had another cybersecurity attack. And this one cost them even more because they refused to put the safeguards in place to a high enough level that it would prevent them from having that second cybersecurity attack. And this is the kind of stuff that is killing healthcare right now, because it doesn't matter how much money we chase, how much money we make opening new services, new clinics, and stuff like that, because we're losing way too much money on errors, on inefficiencies, and on the way we do stuff. I mean, and if we've got to get control of that second side of the coin, because it ultimately decides how healthy the bottom line is. I could sit here and tell stories for days of hospitals that chased new money and ended up worse off than they could be because they refused to get control of all the money that they were losing or wastefully spending on stuff.
Well, and we've talked a little bit from the regulatory side where they had this tit for tat game, but it's not just impacting it from the regulatory side. We're seeing it from the payer side too. I mean, a lot of it is what's caused never events to be a thing and even come up. So talk a little bit about that.
When in the 80s, when I was a quality director, we got paid for every error that came out of the way we delivered patient care. And so in some ways, we actually saw it as added revenue. Some people did. Now, some of us saw it as a problem, and because of the problem it created for the patients and the problem we saw that it would create long-term for the healthcare industry if we didn't get control of those errors. I mean, what's happened to healthcare was highly predictable. I could go right through the timeline of the conversations I've had since the 80s with different groups and different people about, if we don't get control of this, somebody will step in and start exercising more control. If we don't get control of this, it's going to impact how much we get paid. If we don't get control of this, it's going to impact what we get paid for. And those conversations continue to play out. Yet the industry is not doing enough to get control of what the negative outcomes that those stories create. All right. So a never events are a great example of that. Because what happens with a never event is, like when I was a quality director, if a patient had an infection, we got paid to treat the infection. If we cut off the wrong leg, we got paid to go in and take off the other leg. I mean, it was just this, and everybody was so caught up in the excitement of what we were able to do. Yeah. Nobody stepped back and said, what are the consequences if we do not do this very well? And so along came never events. And all of a sudden we had this little teeny tiny list of never events that we would no longer get paid for if they occurred during patient care, because we had figured out that the world had figured out that if a patient ended up with a surgical infection in their abdomen after a surgery, the most probable cause of that infection was something that happened during surgery. We just couldn't blow it off anymore as this thing that just happens to unlucky patients. And so never events were born. And so we had this little teeny tiny list of things they said, well, if these things happen during a patient's care, the hospitals aren't going to get paid for them anymore. And then the list just kept growing and growing and growing, to the point where now, while we talk about never events, it's just easy to have a never event and it doesn't even really have to be on the list, because the payers are now driving the bus for what gets paid for and how much we get paid. And so they just say, well, we're just not going to pay for that. We're just not going to pay for that. And so it's just a mess. The whole environment is an absolute disaster, because healthcare is not the only player in this that has what they call status quo biases, where it just, no matter how obvious it is that this is something's not working and we need to fix this, we just keep doing it the way we've always been doing it, because for a lot of reasons. Payers are doing the same thing. The regulators are doing the same thing. The survey companies are doing the same thing. And so it's like this great big huge house of cards that's just getting more and more fragile every single day. And at some point in time, it's going to collapse. And while our providers will more than likely be the first ones to go down as it collapses, they're not going to go alone. because this is just too big a convoluted mess right now. And the patients and the American people are going to start asking some really serious questions about how this got to be such a mess, how they can't access care. I mean, it's like right now, we have so I'll give you a story because I think it's a great example of all this. So there's this hospital that put up this big, beautiful addition on its campus, okay? Because it was going to make big money with all the new services that it could house in that addition. And it built that addition during one of the most expensive construction times we have seen in this country in a long time. And so it got the building all built, and money was so tight when it finally got it built that it put a moratorium on hiring new nurses. And so it just decided that all the nurses it already had employed could just work harder to take care of all those patients that new building was supposed to service. And then when the money kept getting uglier, it decided that it would lay off about 24 of its physicians. Now, physicians are the money-making engine of any healthcare organization. No doctor, no patients being seen, no money being made. But it laid off 24 of its physicians. And so that great big beautiful building, which they built on borrowed money when interest rates were high, is now like this great big huge albatross around their neck.
Yeah.
The patients aren't happy. They're struggling to pay their bills. And this is what the environment looks like in way too many settings. And we have to just wake up to the fact that we cannot just keep chasing more in the undisciplined ways we have for the past 50 years. And then, and expect everything to be fine, especially when we are not in control of all the wasteful spending and losses that we incur when we manage to the 100.
Well, and when you talk about that, I mean, that's a big example, right? But we work with hospitals every day, and we see just from a little changes can save or add up to save big money. But thinking outside that box and getting away from, well, we've always reported it this way, we've always documented it this way, and trying to get away from that mentality and looking at it from the perspective of how can we do this better so that it benefits us, saves us money, keeps the patient safe, doesn't skip steps. It isn't a Band-Aid, but it can be done better and more efficiently to move us forward.
Exactly. And that's a big thing that is that's huge for us right now, is because I'll give you another example. So I was having a conversation with a hospital that was looking at making some changes because it's just like everybody else. They've got a staffing mess. And so we were talking about an idea, and I said, we've got hospitals where even a little tiny critical access hospital that figures it's freed up about 6 FTEs, most of them being nurses, engaging in the changes I was proposing. And the person on the call said, well, how much would it cost us to do this? And I said, to get started, I said, for just your smallest organizations, it would probably be about $300,000 a year. And she said, $300,000, we would have to take that money away from some piece of equipment we want to buy. And I said, I know that. I know how tight money is. But if you could spend $300,000 to initially save somewhere between 1.2 and 1.9 million, I think it's worth the investment. I said, because with time, a little bit of time and a bigger focus on efficiency, effectiveness and stuff, you could probably save about 10 times that. Yeah. And she says, I just don't know if we could take that money away from buying the next piece of equipment we want. And see, this is what is going to kill healthcare.
It's that same whole mentality where you want something that you can show for it. And they don't think they can show fixing processes as moving forward, but moving backwards, starting from the basics and building back from the ground up is going to get you farther ahead than just buying that next piece of equipment that you're going to struggle to even use efficiently and make money off of.
Sure. I remember when I became CEO of the hospital, I was partly in that hospital because the state really wanted it to survive. And so I was asked to go in there and to put together a plan on how to save it. There were some things about that particular hospital that it just couldn't close at that point in time. So somebody from the state health department called me and they said, we've got grant money we could free up for you. If you could give us something to spend it on. And I said, sure. I sent them this document. I wanted to spend that money on management and leadership training for my people. And this individual calls me back and she says, don't you have a building you want to build or some part of the building you want to renovate? We could get the money for you easier if you would spend it on something tangible like that. She says, but I don't know if I can get you the money for management training. And I said, but I have a whole building full of people who have been elevated into their positions and they don't know what they're doing. They will do it if they just know what they need to be doing. I said, there's no sense in expanding the building if I can't run it.
Yeah.
And they finally did give me the money. But see, this is the kind of stuff that for 50 years has been playing out in healthcare. We'll give you the money to put up another building or this or that. And it doesn't really matter if in the long haul, it's a liability or actually an asset. Because we measure things in healthcare in terms of things or processes. That's another problem with the way we do quality. We don't measure quality in terms of outcomes. It's like when I was the quality director of my hospital, I would put all this stuff together for the surveyors, and it's even worse today. So did you fill out that form? Did you, do this? Did you submit this data? Did you do that? And then when you go back and you ask try to find an outcome in it, there isn't any. Because the process has become the outcome.
Quality can't be quantified. It's qualitative. You cannot put a number on quality, but if you look at it a little bit differently, you really can.
Other industries put a number on it every day. I mean, there is a qualitative part to it, like patient satisfaction. Are the patients happy? We don't even do a good job at that, measuring patient satisfaction. And it just, we've just got to step back away from the mess. And we've got to now look at it with a fresh set of eyes in healthcare. Because if we don't do that, this is just going to get worse and worse and worse because our country is now in a situation where money's just not going to magically appear for us. It's like this $50 billion that's been set aside for the rural hospitals. I'm excited and terrified all at the same time. Because if that money gets spent the same way we've spent money over the last 50 years, nothing will come out of it. Our rural hospitals will still die. And people will still be left with these healthcare deserts. Because it's kind of like, here's a good example. Let's talk about EHRs for a second, okay? Our industry, we've been talking about the importance of EHRs or a tool like an EHR since the beginning of the technological revolution. When we realized there was going to be a lot more information we had to manage about a patient to successfully manage their care. And because of this whole business of chasing more and not wanting to spend money on the other side of the coin, healthcare kept balking and pushing back. And it didn't take control of the process. So finally, the government came in and said, and in order to get paid in the future, you will have an EHR. All right. And then they came up with this teeny tiny list of measures called meaningful use measures on how you could successfully prove that you were doing a good job with your EHR. And so we spent billions of dollars on this whole EHR thing. And what do we have today? We have EHRs that are costing our hospitals a lot of money, and money that could be smaller. It doesn't cost that much to have, it shouldn't cost that much to have an EHR. All right.
Yeah.
They can't prove that they're having any impact on helping us reduce the incidence of medical errors. They became the straw that broke the camel's back for the nursing crisis. They just started pushing nurses out of the industry and physicians. And now we're spending a small fortune to the 100 in the 110-100 rule to try to slap Band-Aids on them and fix them because we can't afford to replace them, because we blew all the taxpayer money that was set aside to build them. And part of the problem with that is because healthcare was so busy chasing more, looking for another piece of technology to buy or build another building, we let people who didn't have to know anything about patient care, the delivery of safe and effective patient care, have at it and build them.
And on top of it, they don't even talk to each other. You can go from one hospital to another that is using two different EHRs, and they're not going to communicate. That new hospital doesn't even know what your care has been.
I mean, it's a little bit better right now, but there was a time when one hospital could have as many as 5 to 8 EHRs for each of their little different kingdoms of patient care, and they didn't have to talk to each other. Because you know why? That wasn't a requirement in the meaningful use list. Yeah. And so everybody built their own little EHR, and it didn't necessarily matter, the ultimate impact it had on patient care. So the question for me is, how is that $50 billion for the rural hospitals going to get spent? I mean, because to be honest with you, every time there's new money that flows into healthcare, there's thousands of antennas that go up because everybody wants a piece of it, And so a lot of time I have actually seen buckets of money like this, where by the time the money actually gets to the healthcare provider that's supposed to benefit from it, there isn't any left.
Wow.
Because it's all got sucked up by all these players who say, we'll help you. We'll do this for you. We'll do that for you. We'll give you an EHR. And healthcare, and the only people who can change that are our healthcare providers.
Yeah.
Our healthcare providers have to decide they're going to fix themselves. We're going to take that money and we're going to fix ourselves, and we're going to give up the land of status quo bias, and we're going to figure out what we have to do to truly fix ourselves. It's kind of like our clients we work with right now. They're all over the spectrum. When we put together SQSS, my goal was to build a tool that would help our hospitals raise their bar on quality. At the same time, they saved money, freed up manpower, and created the data they needed to be a preferred provider, right, to be in control of an environment that for 50 years has been working against us. And we have some hospitals that use the tool that way. They use the tool to get ahead. I can actually have conversations with them about, so if we put this in SQSS, how much money could we save? Or how many man hours could we free up? We have others that they're using it to survive status quo. They do just enough in it to stay out one step ahead of the surveyors, but not enough to help their hospitals really get ahead.
Definitely.
And so it becomes harder and harder for them every year to survive status quo because they're not using the features in the system that are specifically designed to help them get ahead.
One of the big focuses with it is to try to help push the data where it needs to go, right? So to start to remove the silos. But in order to talk about silos and what that really means is, can you tell me from your perspective, because you hear quality talked about as QA, you hear some people say QI. I mean, maybe it's PI. It depends on where you are in the country, what meeting you've been at, who you've listened to, and what they consider quality. There's a huge gap in what quality is considered in healthcare. And so tell me from your perspective, what is quality for healthcare? What should it be?
Quality should be the same thing for us that it is for any other industry. And that is to be in control of anything and everything that can either financially, operationally, or reputationally hurt the business. Okay? It's not to play a game of tit-for-tat with regulators, surveyors, and other types of players. It's not that these people's intentions are bad, but it's the dynamics of the game and the way the game gets played that makes it bad for everybody. You know, surveyors aren't getting ahead these days. Regulators are struggling. Everybody's struggling. And it's because of the game. But, you know, here's a good example. You know, instead of figuring this out for itself, what is quality in healthcare? And how do we manage quality in healthcare? When I first became a quality director, the language was quality assurance. We had to have quality assurance programs. And that was partially because the government had been watching the phone company break up. Ma Bell, when I was a child, we had one phone company. It was Ma Bell. And then the phone company, Ma Bell, started breaking up into all these smaller companies. And they were trying to figure out how they were going to have the most customers. And so they started building these quality programs. And they, to compete with one another. And we were in the early days of our technological revolution. We were having problems. The government decided, well, healthcare needs a quality program. And so they mandated quality assurance programs. All right. And because of some of the dynamics and the way that all played out, it didn't go very well. It was just like this antagonistic game of back and forth. So eventually, what happened is that it wasn't going so well, and the other industries were starting to talk about QI. And so so all of a sudden we had this mandate and a shift in language from QA to QI. Okay. And I remember going to a conference with some of my fellow quality directors. And we're sitting there and these people stand up there and they say, well, we're not going to measure QA anymore. We're going to measure QI. We're going to look for QI when we come into your buildings. And we're sitting there as a group and one of us puts up our hand and I said, well, so how does that work? Because if I understand QA and QI, QA is about being in control of the environment. QI is about improving it. And they never really answered the question. But all of a sudden, all the language shifted from QA to QI. So then we got into the mid-1990s and things weren't going so well. And the other industries were all starting to talk about PI. And so all of a sudden, the language shifted to PI. And for most hospitals, all that meant was paying somebody to sit there with a word processor and change the word QI or quality improvement to PI or performance improvement every place it existed in one of our documents. And it never actually changed anything. And it's a huge piece of why the healthcare industry is such an absolute mess right now. Because we have terrible QA. We have terrible terrible processes for being in control every single day of those things that are important to patient safety.
And I think that's part of the problem with the perspective that people have. I can't tell you how many times I've had an eye roll or something to that effect when we talk about a new regulation that's coming out. But the problem is the reason the regulation is there is because bad things happened. And most likely those bad things happened to a patient. And nobody fixed what caused it themselves. So somebody felt like they needed to step in. So if we can get in control of that ourselves, it's going to stop that.
And that's exactly what I want people to use SQSS for, to get in control of that, stuff, but do it in a more business smart way, because those things just keep growing. It's like we have one critical access hospital right now that's using the system. They've been using it for a while. They have over 40,000 tasks in the system just to manage QA every day. Okay. And when that number started to grow, the CEO said to me, she says, I knew there were a lot of them. I had no idea how many there were. For the average 100-bed hospital right now, that list is over 100,000 things. License renewals on their staff, CPR certifications, crash cart checks. You take all the things that we have to be in control of every day for the safety of the patient care environment, the list is enormous. And you know what the process is in a lot of hospitals? You just look at the managers and you say, well, just make sure it all happens. Just make sure it all happens, because we don't want to spend the little bit of money it would take to help them make sure it happens.
So that we get our turnover from is the frustration from things like this. And it is so hard to keep things up to date with the turnover that you see.
Well, yeah, it's like a conversation I was having yesterday with a hospital. They have a brand new med-surg manager. And the comment to me was, and we do not want this one to fail. We think she's got great potential. She has no experience. We do not want her to fail. So how do we use SQSS to help make sure that happens? And see, but in the past, we've never had those conversations. We would throw that person into that position. She would be left on her own to sink or swim. And then we would wonder why she quit when she hadn't even been there a whole year yet. Yeah. There is a lot of pressure on our caregivers these days. And the question is, what are we doing to change that, to improve those odds? Yeah. And it starts with a different attitude about what quality really is, why it's important. And that attitude has to come out of the C-suite, because for years and years and years, our quality programs have been designed to give cover to the C-suite so they could keep chasing more. Mm-hmm. And then people like me, I can remember one time when the surveyors were in our building, and the surveyor said, we were sitting at the table with the senior leadership team and some of the managers, and the surveyor said, looked at one of the people and said, so what's your role in quality? And this was one of our senior leaders. And he just looked back at the surveyor and he points to me and he says, that's her job. No, it's everybody's job.
Yeah.
It is everybody's job to make sure that every day, everything and anything that can hurt our hospitals, hurt our patients, hurt our workforce, and hurt our reputation is being managed to minimize the fact that there could be harm that comes out of that.
And I think that's an important part of this conversation is not to beat down on the providers and the nurses, because they are so overworked. There is a lot of pressure, but this mentality comes from the top. It needs to come from the top down to create an environment where quality is important for the organization as a whole.
I agree, because one of the things that worries me really a lot right now is the fact some of the things that are playing out there. So now we're having a conversation because we have such a physician shortage. We're having a conversation about reducing how long they have to go to school. So we got all these medical errors. We got all this hypercomplexity. We got all this tight coupling in our patient care that increases the risk that we can hurt a patient. We got all this knowledge that we're not managing very well, as what we understand about disease processes and patient care evolves. And the answer is to just let them go to school for a lesser period of time. Or it's like what's going on with the nurses right now. We have a situation where the goal is to get them out of their nursing programs faster. So prior to that being the decision, the answer, instead of fixing what drives them out of the profession, we're just going to let them go to school for a shorter period of time and throw them into an increasingly risky situation. So prior to that being the answer, what we had a study that was put out there that showed that 17% of all new nursing graduates were quitting the profession within 1 year of employment, and 33% were quitting within 2 years because they could not deal with the stress that the environment creates for them.
Yeah.
And so what is our answer? Our answer is to put even less prepared people into an ever increasingly stressful environment and think that's somehow going to fix something. We got to clean up all the busy work. There is so much money and there is so much manpower to be freed up in healthcare right now that it's just mind-boggling. But it's not going to happen unless our healthcare leaders decide that they are going to do it, that they're going to get rid of all the wasteful forms. They're going to get rid of all the stuff that frustrates the patients and serves no purpose. They're going to drive a level of efficiency and effectiveness into their buildings that frees up money and frees up manpower. And they're going to recognize, because here's what happened, just real quick. Here's what happened. When I was the CEO of that hospital and I had that survey, and we figured out just that one form was going to consume the time of 5 nursing FTEs. By the time we got done talking about all the different things that the game of tit-for-tat would normally sanction as being a great idea, we were up to almost 10 FTEs. And we didn't implement any of them. And when the surveyors were getting ready to leave the building, the physician surveyor came into my office and he said, "I just want to thank you for a great survey." And I laughed and I said, I'm not sure I would describe it that way. It was pretty stressful for me. And he laughed and he said, "I know." He says, "But we were just sitting in the boardroom talking about all the conversations we had had about money and quality, and how they really are two sides of the same coin, and how some of the stuff we could accept or we could recommend actually is harmful to quality, not helpful." And so he and I had a really great conversation about that. And then he looked at me. I'll never forget it as long as I live. He pulled his glasses down on his nose, stared straight at me, and he said, "But I also want you to understand that the only reason you won every one of those conversations is because your goal for quality was bigger than what we had to look for." And see, that is where we now need to take healthcare.
Getting away from step.
Yeah. Our goals for quality have to be bigger than what the game accepts.
Yeah.
Because if we do that, we will be amazed how much better life could get for our hospitals and every other type of provider that's out there.
So based on this conversation, where do we go from here? How do we start to fix this then?
Well, the first thing is to just recognize that we cannot continue to do things the way we've been doing them and expect to survive. I mean, I'm terrified what's going to happen if we keep doing things the way we've been doing them, losing money the way we've been losing them, losing staff the way we've been losing people, what's going to happen to healthcare? Because I have people say to me all the time, well, we have to survive. We're healthcare.
Yeah.
And the answer to that question is healthcare has to survive. There's nothing that says it has to survive in its current form.
Absolutely.
And even if it does survive in its current form, there's a big difference between surviving as a successful business and surviving as one of the walking dead.
Yeah.
And that's where we're headed in healthcare right now. We have a lot of hospitals out there where it wouldn't take much of another crisis to push a lot of them right over the edge, and they will cease to exist because they're just barely hanging on and paying the basic bills. All right. So we have to step back and we have to look at stuff, and then we have to change our quality model. We have to get away from tit-for-tat and the bureaucratic quality culture that we have operated in since the turn of the new century. And we need to start moving to what they call a generative safety culture, one where the goal is to manage to the one, to get so much right the first time that you save money, you free up manpower, and you make the patients happy. And it's not that hard to do. You know, when we were working to turn that hospital around, we didn't turn it around building more buildings and adding more services. We just turned it around getting control of all this stuff I'm talking about. And we took a lot of patients away from our competition. Just because, like, patients would say to me, or people would say to me when they'd stop me in the communities, they'd say, we can always count on coming to your place, and you guys will keep us safe. You know, that's bigger for that in the patient's mind than we understand. Patients want to feel safe. They do not want to think that, you know, what are we accomplishing when we put up a new building and it doesn't improve turnaround time on appointments? Yeah. Patients can still go sit in the waiting room and feel themselves physically aging as they sit there. And then they can't talk to their doctors because the doctors are too busy trying to cover multiple locations. And I mean, what are we accomplishing? Yeah. We certainly aren't building a type of patient confidence that if we get ourselves in another mess, the public's going to come back and say, oh, but this hospital has to survive, or this healthcare system has to survive. Yeah. They're only going to do that if they feel that we are meeting their needs and we're giving them the kind of experience they keep looking for.
Well, and they're looking for that provider that makes them feel like they care. They know who they are when they walk into their office, and they know their care I mean, that's important.
You know, it's kind of like right now, my parents are 87 and 86 years old, and I cannot let them go to the doctors by themselves. It's not that they can't physically go. It's just that doctors don't communicate well with one another. It's easy for issues that are important to them to get lost. It's like I took my mother the other day for an appointment. Now, we have seen this doctor almost a dozen times, and my mother has a fairly rare collagen disorder that accounts for a lot of her physical issues. And we're sitting there talking about, you know, her some issues, other issues she was having. And I popped up and I said, well, you know, I think a lot of it has to do with her Sjogren's. And I said, because of the way it impacts her fluid, her body. And this doctor looked at me and said, oh, yeah, that makes perfect sense. That probably is part of the problem. Now, that's in her chart. It's in every conversation we have when we go there. And yet it was this great big revelation that my mother has Sjogren's. Yeah. And so because it has a huge impact on the care that she gets, the drugs you can order, and this and that. And it's not that this is a bad doctor. This is a doctor that is typical of what exists right now in healthcare. And she is so unbelievably overwhelmed in systems that do not effectively support her that she can miss an important point like that.
Yeah.
And then we wonder why our patients talk bad about us. It's just mind-boggling to me that we haven't made those connections yet.
Yeah.
And so it's now about getting control of this stuff and doing it in a way that we can show measurable impact and measurable difference. I don't care if here's how I look at it these days. I don't really care how well you do on your survey because it's a measure of minimal compliance.
Yeah.
Surveyors, and it's not the surveyor's fault. It's how the game of tit-for-tat has evolved. They come in, they have a set amount of time to look at things in an environment that keeps evolving and growing, and the measure of success is always minimal compliance. Are you minimally in compliance with whatever the standard is? And then we hang our hat on that. We say, oh, we're accredited. Well, what does that really mean? Does it mean that the next time you take my mother to the OR, you're not going to screw up her surgery? What does it mean to be accredited? Because it's not a measure of excellence. It's a measure of minimal compliance.
Yeah.
That's why we can still have doctors get credentialed by a hospital and never have been to medical school. We're still seeing those stories every once in a while. And it's because their credentials folder didn't make it into the teeny tiny list of credentials folders that the surveyors look at. And the hospital has an unbelievably weak credentialing process. And so these guys can slip through the cracks. And they can actually be treating patients and never been to medical school. I saw a lot of those when I worked for the medical malpractice insurance company. You don't see them as much today, but every once in a while, you still see a story about some doctor that's out there treating patients and he never even been to medical school, or she had never even been to medical school. And it's all because of the strength of our quality programs, our quality and risk management programs.
What would you like people to think about before the next podcast comes out?
I think what I would like people to do is I would like them to just step back, like I said, and start looking at their environments through a different set of eyes. Okay? Take off the rose-colored glasses that have been passed down from leadership generation to leadership generation since the 1970s and start looking at their patient care environment through a different set of eyes. We have to understand this it's not about us being bad. It's about how we're exercising control over the environment. And when we do not exercise control over the environment in a way that effectively protects the patients and makes them feel personally cared about, then next step is to decide we're bad. Okay? And so we have total control of that. We could totally control that if we chose to. So step back and ask yourself. And then one of the things I want to talk about on the next podcast is how to start retooling the environment to do that. All right. How do we, because right now, one of the things with the game of tit for tat that's very dangerous for us is instead of us trying to understand and recognize all the risks that impact us in a timely enough manner to be in control of them, we sit back and we wait for the game of tit for tat to dictate what the next thing is. Okay. Yeah. We sit around and wait for the next set of rules and regulations or survey standards to come out. And then we figure out how we're going to minimally satisfy them.
Yeah.
And what we now need to do is we need to have a way to effectively create, be out in front of those risks. As fast as we bring in a new service, What are the risks that come with that? And what are we going to do to be in control of that? It's kind of like the bright idea feature we're just getting ready to release to our hospitals. The staff knows. When I was CEO of my hospital, I'd go to meetings with the area CEOs, and they would say to me things like this. So why do you give your staff so much control over telling you what's broken and what needs to be fixed? And I'd say, because they know what's broken. I don't.
Yeah.
And I want to know what's broken before it hurts what I'm trying to accomplish.
Yeah.
We need our staff not being afraid to tell us that stuff, but being willing to tell it. It's like I was talking to one of our hospitals the other day. They've started aggressively using that feature where you can easily respond. Every time somebody submits an incident report, they can easily respond back to that individual, thanking them, telling them the difference it's making for patient safety or employee safety or whatever. And the risk manager asked to have a call, and I said, so what do you want to talk about? And he says, I want to talk about the fact that our number of incident reports have increased 4-fold since I started doing that, and I need to figure out how to manage them all.
Yeah.
He says, when I started sending those messages back to people realized we were actually doing something with them. We were actually reading them, and we were actually trying to make patient care safer. And so he said, also all of a sudden people started reporting a lot more stuff. He says, it's not that we have more incidents. He says, they're just telling us because they're not afraid to tell us.
They're getting a positive outcome from it. It's not negative. We're not trying to get you in trouble. We're trying to fix what's broken. So tell us.
That's right.
Yeah.
And see, those are some of the things. That's why the C-suite's so important in this. Because if you ever read any of Edgar Sheen's work on the creation of a culture and the management of a culture, he says that the workforce creates the culture. But the leadership controls all the variables that decide where the workforce can take that culture. And see, for years and years and years, we have put our thumb on the workforce because it was just easier if we didn't know. See no evil, hear no evil, speak of no evil, there can be no evil, even if it's by design. And now we need our employees telling us where every single risk lives in our building. And hopefully doing it is something called great catches. They recognize a risk. They tell us about it before it ever has the chance to get inside a patient care activity so that we can put the safeguards in place so it never has the potential to hurt a patient. And so I just would like people between now and the next podcast to start looking for some of that kind of stuff, to start assessing your own internal quality and risk management activities for whether or not they play to status quo biases or they are actually generative in their efforts to get out in front of what can hurt us and hurt our patients. I'd also encourage people to go out, if you want to just read more about or listen to more about this particular topic, you could go out and visit our website. There's a piece out there titled An Industry in Crisis, where I talk about other examples of what makes us an industry in crisis. And that would probably be a good thing for people to do. But, it's in us. You know what? It is in us to fix healthcare. And you would be surprised how much easier our lives would be if we did fix healthcare. Right now, we are spending way too much time and money on chasing stuff after it's an issue. It's like this CFO who didn't have time to have the conversation with me about how to prevent that cybersecurity attack, another one.
Mm-hmm.
So then he got to pay for a second one, and it was much more expensive. This is the kind of stuff that's going to kill our hospitals if we don't get control of it.
Thank you for taking the time to talk about this today. For anybody who wants to go out and check out the website, it's www.qualitycalendar.com.
If anybody has any specific questions for us, I'd be happy to answer them for you. If you go to that website, our website, there's an area where you can post your questions, and then I will be happy to respond to them.
Thank you for hanging out with us today. We hope you found this conversation interesting, and have a great day. We will hope to see you on the next one.